Question number 7 is temporal arteritis. All are true except number A, blindness is not seen, branch of external carotid artery, temporal artery tender and inflamed, and headaches in temporal region. So the correct answer for this question is blindness is not seen. Blindness is not seen. Now why? Because the superficial temporal artery is a major artery of the head. It arises from the external carotid artery and it bifurcates into superficial temporal artery and maxillary artery that we all know. The temporal artery is the name of a specific artery located on each side of head. In temporal arteritis, this vessel become inflamed and causing pain, weight loss, muscle aches and certain time dizziness of the scalp. So fever is also associated with these kind of lesions. Also temporal artery, when it causing pain in the jaw opening, it is called as jaw claudication. But the temporal artery and visual loss, the temporal artery is in emission of blood vessels, so it can lead to permanent visual loss and other symptoms because it causes severely reduced blood flow. Visual loss occurs in around 25% of the patient, so it is not a very small number. So yes, the answer for this question goes with about the blindness. Because temporal artery can quickly progress, arteritis can quickly progress to cause severe irreversible visual loss in both eyes. Prompt attention is required when this condition is suspected. Usually the visual loss occurs due to temporal arteritis is permanent, so there is no cure for them. So the best one is ki you can diagnose it earlier and then intervene with proper antibiotics. So question number 8, Mohs surgical technique is, it is a wide excision of tissue, or B, used in removal of tissue at basal cell carcinoma, option C, recurrence rate is high, and D, none of the above. So Mohs microsurgical technique, the correct answer is used in removal of tissues of basal cell carcinoma. It is also used in squamous cell carcinoma as well. Why? Because basal cell carcinoma usually affects skin. So Mohs microsurgery has a greatest cure rate in this case. In this technique, instant frozen sections are done to determine when enough tissue has been removed to give a clean margin. 5% fluorouracil, that is FU, 5-FU cream can be used in treatment of superficial lesions. So today, Mohs surgery has become most accepted treatment for removing basal cell carcinoma and squamous cell carcinoma, two most common skin cancer. It accomplishes the trick, the sparing greatest amount of healthy tissue while also completely expunging cancer cells. Cure rates for BCC, that is basal cell carcinoma, and squamous cell carcinoma are at unparalleled 98%. So it is the gold standard in treating basal cell carcinoma and squamous cell carcinoma. So what they do is, skin have multiple layers like this. So what they do is, they start to excise one layer and then send this section for frozen biopsy. So results are immediately retrieved and you can know where your skin has become clear of your cancerous or malignant cells. So as soon as you know the malignant cells are over, you can stop your procedure and you can salvage as much as of healthy skin you can in this procedure. So the correct answer is Mohs surgery is used for treatment of basal cell carcinoma. Coming down to next question. White sponge nevus, the true is A, it is not a pre-malignant lesion. Option B, occurs at more than 50 years of age. Option C, malignant transformation is common. And option D, has malignant potential in oral cavity. The correct answer is, it is not a pre-malignant lesion. Why? Because white sponge nevus is also known as familial white folded dysplasia, is a rare autosomal dominant disorder. Most commonly, the lesion appears at birth or in early childhood. Neither gender or a racial predilection exists. There is a need of precise identification through the prompt histopathologic examination to differentiate this condition from more serious, potentially pre-malignant lesion as well as other genodermatosis such as hereditary benign epithelial dyskeratosis, lichen planus, lichenoid drug reaction, lupus erythematosus, and cheek chewing and possibly candidiasis. While some of these lesions are benign, Other are pre-malignant or of some disease. Therefore, a early diagnosis of benign lesion is important, and often these lesions needs treatment plan. So if you'll see, of all this, summarizing it is basically diagnosed on the basis of elimination. If you are not getting any other histopathological finding with the biopsy taken for the lesion, it is known as white sponge nevus, because it is a hereditary achieved disease. Question number 10. Tuberculosis can be easily differentiated by squamous cell carcinoma as option A, biopsy can confirm the diagnosis, B, acid positive with Ziehl-Negeler stain, option C, primary lesions occurring on the tongue, and option D, direct smear examination. So it's a clear cut and a straightforward answer. Biopsy can confirm the diagnosis. Oral lesions of tuberculosis are seldom primary, rather they are always secondary to the pulmonary form. They may occur at any site on the oral mucosa, but the tongue is most commonly affected, followed by buccal mucosa, gingiva and frenula. The presence of acid-fast bacilli in the sputum smear is gold standard in diagnosis of TB. So, bacilli appears pink on Zn staining. So, ultimately you have to take a biopsy. You can take an incisional biopsy for lesions greater than 1 centimeter, or if you are planning for an excisional biopsy, you can go for complete wide excision and then send it to the histopathology. So, they will confirm you what kind of lesion it is, whether it's a squamous cell carcinoma or it's a tuberculosis. Question number 11. Diplopia is common complaint with option A, ketamine use, B, propofol use, option C, nitrous oxide use, and option D, none of the above. So, question answer is option A, the use of ketamine. Ketamine is used in kind of a dissociative anesthesia. So, ketamine is an anesthetic agent well known to cause both nystagmus and diplopia at high doses of anesthetic doses. Potential side effects of ketamine includes dizziness, diplopia, dysphoria, dreams, hallucination, disestrange sensations, lightheadedness, sleep difficulties, confusion, and though they are less common when used epidurally. So, but yes, these all are temporary features, and once the ketamine is out of your system, you will become normal. So, diplopia is a double vision which is commonly associated with dissociative anesthesia in ketamine. Question number next 12. While tissue biopsy for preservation, which of the following chemical is used? So, it's a straightforward answer, option number A, which is 10% formalin. Fixation is the single most important determination of high quality histological section. Therefore, 10% neutral buffer, the most widely used fixative for routine histology, is formalin. Now coming down to next question. The T1 weighted MRI is used and seen as option A, fat and blood appears hypertensive, B, fat and blood appears hypotensive, option C, fat appears hypertensive and blood appears hypotensive, and option D, whereas fat appears hypotensive and blood appears hypertensive. So they have given you a permutation and combination to make you furthermore confused about this question, which is a straightforward directed question. Answer for this question is option A, fat and blood appears hypertensive. So basically MRI have two windows, a soft tissue window and a hard tissue window. So we say it as a T1 imaging or T2 imaging. So when we talk about T1 imaging, we usually say it has to be a soft tissue window. So when you want to evaluate soft tissues, we go for a T1 window, and if you want to visualize the hard tissues like TMJ, condylar head, mandible, nasal bone, frontal bone, then you go for a T2 weighted imaging. Material returning high signals on T1 weighted sequences are fat, subacute hematoma, melanoma, flowing blood, paramagnetic contrast agents, and white matter. So making it simplified for you, the correct thing is you just remember that T1 is for a soft tissue window and T2 is a bony window. So whatever tissues that will be seen in T1 window should appear hypertensive so that you can visualize it clearly. So that's why the answer for this question goes as option A. So here I have given you a table that what appears dark on T1 weighted imaging and what appears brighter on